We will cover hypertensive crisis. Uncontrolled hypertension can lead to a sudden and severe increase in blood pressure. This increase is known as hypertensive crisis. A hypertensive crisis is a medical emergency. It can lead to a heart attack, stroke, or other life-threatening health problems. Seek emergency medical help for anyone with these blood pressure numbers. Severely high blood pressure can damage blood vessels and body organs, including the heart, brain, kidneys, and eyes. During a hypertensive crisis, the heart may not be able to pump blood as well as it should. A person who is experiencing hypertensive crisis may have a systolic blood pressure reading of 180 mmHg or higher and a diastolic blood pressure reading of 120 mmHg or higher. BPs often can be greater than 220 by 140 mmHg. Around 1 to 2% of adults with hypertension will experience hypertensive crisis. Some people will experience symptoms while others will not. Hypertensive crisis can damage blood vessels and major organs. There are two types of hypertensive crisis: hypertensive urgency and hypertensive emergency. Hypertensive crisis is an umbrella term for hypertensive urgency and hypertensive emergency. These two conditions occur when blood pressure becomes very high, possibly causing organ damage. Hypertensive urgency occurs when blood pressure spikes. Blood pressure readings will be 180 by 110 or higher, but there is no damage to the body's organs or symptoms. Blood pressure can be brought down safely within a few hours with blood pressure medication. Hospitalization may not be needed. Hypertensive urgency is more common. It may be associated with chronic, stable complications such as stable angina, chronic heart failure, or prior MI or cerebrovascular accident with no threat of an acute event. Hypertensive emergency means blood pressure is so high that organ damage can occur. Blood pressure must be reduced immediately to prevent imminent organ damage. Blood pressure will be 180 by 120 mmHg or greater in emergency hypertensive crisis. There is life-threatening damage to the body's organs. Hypertensive emergency occurs when a person has the readings above as well as the associated symptoms. The differences between hypertensive urgency and emergency are the presence of target organ damage and the types of treatment the patient will receive. Hypertensive emergencies and urgencies may occur in patients whose hypertension has been poorly controlled, whose hypertension has been undiagnosed, or in those who have abruptly discontinued their medications. Once the hypertensive crisis has been managed, a complete evaluation is performed to review the patient's ongoing treatment plan and the strategies to minimize the occurrence of subsequent hypertensive crises are implemented. Organ damage associated with hypertensive emergency may include changes in mental status such as confusion, bleeding into the brain causes stroke, heart failure, chest pain that is unstable angina, fluid in the lungs that is pulmonary edema, heart attack, aneurysm which may lead to aortic dissection, eclampsia that occurs during pregnancy. What are the causes of hypertensive crisis? Hypertensive crisis causes include acute aortic dissection. An acute aortic dissection is a serious condition in which a tear occurs in the inner layer of the body's main artery. Hypertensive crisis can be caused by exacerbation of chronic hypertension, head injury. Monoamine oxidase inhibitors are taken with thiamine-containing foods. Rebound hypertension. It happens from abrupt withdrawal of some antihypertensive drugs such as clonidine or beta blockers. Failure to take prescribed blood pressure medicines. This is the most common cause. Suddenly stopping the use of blood pressure medicines and certain heart medicines including beta blockers. Medications interacting with each other can cause hypertensive crisis. If the person is not receiving higher doses when current doses aren't enough to manage, hypertensive crisis occur because of the kidney disease, endocrine issues, preeclampsia or eclampsia during pregnancy, use of some recreational drugs such as cocaine, amphetamines, brain tumor of the adrenal gland called pheochromocytoma. Medications which cause hypertensive crisis are steroids, medicines for depression, cyclosporine. Cyclosporine is an immunosuppressant medication. Pseudoepiphrin. Pseudoepiphrin is used as a nasal decongestant. A hypertensive crisis occurs more often in patients with a history of hypertension who have not adhered to their medication regimens or who have been under-medicated. Rapidly increasing BP can cause the shattering of the endothelial surface due to turbulent blood flow within the vessels, leading to further vascular damage and the release of more vasoconstricting substances. A vicious cycle of increased BP follows, leading to life-threatening damage to target organs. Hypertensive crisis related to cocaine or crack use is a frequent problem. Other drugs such as amphetamines, phencyclidine, and lysergic acid diethylamide can cause a hypertensive crisis that may be complicated by drug-induced seizures, stroke, MI, or encephalopathy. Now, we will see the pathophysiology of hypertensive crisis. The transition from mild hypertension or normotension to hypertensive crisis usually is precipitated by an event that leads to an abrupt increase in blood pressure. Situations associated with this event may include cessation of hypertensive medications with the potential rebound effects, consumption of illicit drugs, and severe pain, as well as several clinical syndromes. Blood pressure is determined by the product of cardiac output and systemic vascular resistance. In most hypertensive crises, the initial rise in blood pressure is secondary to increased systemic vascular resistance. The rise in systemic vascular resistance is believed to be caused by humoral vasoconstrictors. With the increase in blood pressure, mechanical stress on the arterial wall leads to endothelial damage and fibrinoid necrosis of the arterioles. Vascular damage leads to loss of autoregulatory mechanisms, ischemia, and acute end organ damage, which prompt further release of vasoconstrictors, thereby initiating a vicious cycle. The precise pathophysiology of the hypertensive crisis remains unclear. However, two different but interrelated mechanisms may play a central role in the pathophysiology of the hypertensive crisis. The first is the failure in autoregulatory mechanism in the vascular bed. The autoregulation system is a key factor in the pathophysiology of hypertension and hypertensive crisis. Autoregulation is defined as the ability of the organs to maintain a stable blood flow irrespective of alterations of perfusion pressure. If the perfusion pressure drops, the corresponding blood flow decreases temporarily, but it returns to normal values after the next few minutes. In case of autoregulation malfunction, if the perfusion pressure drops, this leads to decrease in blood flow and an increase in vascular resistance. In hypertensive crisis, there is a lack of autoregulation in vascular bed and blood flow, and so an abrupt increase of blood pressure and systemic vascular resistance can occur, which often leads to mechanical stress and endothelial injury. The second mechanism is the activation of renin-angiotensin system, leading to further vasoconstriction and thus generating a vicious cycle of continuous injury and subsequently ischemia. Besides these mechanisms, a prothrombotic state may play a key role in hypertensive crisis. A recent study showed that sp-selectin, that is soluble p-selectin, was significantly higher in patients with hypertensive crisis compared with normotensive controls regardless of the presence of retinopathy, which suggests that platelet activation is a relatively early findings in the pathophysiologic sequelae of hypertensive crisis. Pathophysiology of hypertensive emergency. Initial event is an abrupt rise in BP from an unknown stimulus followed by compensatory mechanisms from the vascular endothelium. This endothelium releases nitric oxide, that is a vasodilator. Arterioles sense the rise in BP and arterial smooth muscle contracts to reduce the rise in BP. Vicious cycle with prolonged arterial smooth muscle contraction leads to endothelial dysfunction and the inability to release more nitric oxide, resulting in further increase in BP. Shearing forces on the vascular wall result in further endothelial damage and dysfunction. Endothelial dysfunction results in the release of inflammatory markers, that is cytokines, endothelium-1, endothelial adhesion molecules. It promotes platelet aggregation, coagulation, and endothelial permeability, vasoconstriction and thrombosis, hypoperfusion, and end-organ ischemia. Patients with chronic hypertension have adapted to the higher BP. Patients who are normotensive and have an abrupt increase in BP do not have any adaptive mechanisms. Even a small abrupt rise in BP can induce a hypertensive emergency. Symptoms of hypertensive crisis. Some people experiencing hypertensive crisis may have symptoms, while others may not have any symptoms at all. People who are able to check their own blood pressure may see a reading of 180 mmHg by 120 mmHg or greater. If no other symptoms are present, recommend waiting 5 minutes and taking another reading. If the reading is still high, the person should contact their healthcare provider for further advice. If their blood pressure is high and the person is also experiencing one or more of the following symptoms, someone should call emergency immediately. Hypertensive crisis symptoms may include severe headache or migraine, dizziness, confusion, severe anxiety, nausea or vomiting, chest pain, changes in vision, shortness of breath, blurred vision, nosebleed, fits or seizures, heart palpitations, nausea and vomiting. Client may not responding to stimulation called unresponsiveness. Symptoms of hypertensive emergency include headache or blurred vision, increase in confusion, seizure, increase in chest pain, increase in shortness of breath, swelling or edema, that is fluid buildup in the tissues. Call emergency medical services if the blood pressure is 180 by 120 mmHg or greater and have chest pain, shortness of breath or symptoms of stroke. The symptoms of stroke include numbness or tingling, loss of feeling in the face, arm or leg, often on just one side of the body, trouble walking, trouble speaking, changes in vision. A hypertensive emergency often presents as hypertensive encephalopathy. This is a syndrome in which a sudden rise in BP is associated with a severe headache, nausea, vomiting, seizures, confusion, and coma. The manifestations of encephalopathy are the result of increased cerebral capillary permeability, which can lead to cerebral edema and disruption in cerebral function. Retinal examination shows X-rays, hemorrhages, or papillary edema. Renal insufficiency ranging from minor injury to complete renal failure can occur. Rapid cardiac decompensation ranges from unstable angina to EMI and pulmonary edema. Patients can have chest pain and dyspnea. Aortic dissection can cause sudden severe chest and back pain with reduced or absent pulses in the extremities. Diagnosis and test. A healthcare provider will take the blood pressure in both arms to diagnose a hypertensive crisis. A physical exam and the test can help find the cause. A healthcare provider will take a number of blood pressure readings and ask the person about their symptoms and medical history. Healthcare provider will ask about the evidence of uncontrolled BP recordings in the past, administration of other drugs that might increase BP, history of sleep apnea syndrome, evaluation of cardiovascular risk factors, and other comorbidities. Also, physical examination should include auscultation of heart sounds for murmurs, neck arteries, and abdominal murmurs. Find neurological deficits, fundoscopy to assess for retinopathy. Check for absence, reduction, or asymmetry of pulses in the lower extremities. Examinations of the abdomen. Urine analysis should be done for significant proteinuria, red blood cells, cellular cast, or analysis for metanephrines in the cases of higher suspicions of pheochromocytoma. A chemistry panel to be done to check for creatinine, blood urine nitrogen levels, electrocardiogram to check for myocardial ischemia or infarction or signs of a left ventricular hypertrophy. An ultrasound of the heart, kidneys, or both can be done. Computer tomography scan or MRI scan of the chest or head to be done. Brain computer tomography scan to evaluate neurological deficit. A chest X-ray of the heart and lungs for the evaluation of cardiomegaly or pulmonary edema. Chest CT scan or transesophageal echocardiography in suspicion of aortic dissection. A fast transthoracic echocardiogram could also be useful to assess the function of the left ventricle to measure the ejection fraction or to detect segmental hypokinesias. Treatment of hypertension. It seems that patients with hypertensive crisis, regardless of whether it is the emergency or urgency subtype, receive treatment mostly in a rather heterogeneous and empirical way. In cases with hypertensive urgency, BP control should be managed with the use of low doses of oral antihypertensive medications, where a gradual decrease of BP over hours to days is expected. Medications that can be used to treat hypertensive urgencies are oral doses of fast-acting agents such as beta-adrenergic blockers, for example, is labetalol, ACE inhibitors, for example, captopril, alpha-2 agonist, example, clonidine. On the other hand, hypertensive emergencies require rapid BP control with a parenteral antihypertensive medication, and in these instances, the patient should be admitted to intensive care unit. The BP should be reduced within minutes to an hour to about 20 to 25% in the first hour, and then to 160 by 100 or 160 by 110 mmHg within the next 2 to 6 hours. However, BP should not be returned to normal values. This is due to the fact that additional BP reduction could cause brain ischemia due to abnormal cerebral flow autoregulation in these patients. An exception to this would be in the case of aortic dissection, where the rapid and immediate reduction of BP within 5 to 10 minutes using initially a parenteral beta blockage, that is esmolol, is crucial for the patient. A great number of medications are available for the treatment of hypertensive emergencies. Sodium nitroprusside is the first choice for the majority of hypertensive emergencies, and it acts within seconds as a potent arterial and venous dilator that decreases preload and afterload. The most important disadvantage is thiocyanate or cyanide toxicity when used for more than 72 hours. The toxicity is more likely to occur if patients have hepatic or renal failure. Next drug of choice is labetalol. Labetalol can be used to treat hypertensive emergencies through IV administration with a non-selective beta blocker and alpha-1 adrenergic receptor blocker, reducing the systemic vascular resistance but maintaining the cerebral, renal and coronary blood flow. It decreases BP without reflex tachycardia. Administer as a bolus or continuous infusion. Despite the beta blocking effect, it maintains also the cardiac output. Next drug is nitroglycerin. Nitroglycerin is a venodilator that mainly reduces the preload and decreases the cardiac oxygen demands, increases coronary blood flow. It inhibits coronary vasospasm, and it is often used in hypertensive crisis. It also causes arterial dilation, but only at higher doses. This agent is used primarily in acute myocardial infarction and acute pulmonary edema, along with other antihypertensive regimens. Other agents that can be used in hypertensive emergencies include nicardipine, which is a useful agent for patients with coronary artery disease due to its beneficial effect on coronary blood flow. Clofazimine, which is a new short-acting intravenous calcium channel blocker. It is a direct coronary vasodilator which increases coronary blood flow, stroke volume, and cardiac output, and also it reduces the peripheral vascular resistance. Nicardipine and clofazimine are dihydropyridine calcium channel blockers. Next drug is phenoldopam. Phenoldopam is an important medication, and it acts through peripheral dopamine 1 receptors as a vasodilator and as a diuretic. It has been shown to be an effective and well-tolerated agent for the treatment of hypertensive emergency. It causes renal artery vasodilation that promotes natriuresis, which inhibits sodium reabsorption. Next drug of choice is esmolol. Esmolol is a cardioselective beta adrenergic blocker which decreases heart rate and myocardial contractility without vasodilation. Acute hypertensive crisis may occur before or during operation, and they should be treated intravenously with sodium nitroprusside, phentolamine, or nicodipine. Sodium nitroprusside is an ideal vasodilator for intraoperative management of hypertensive episode because of its rapid onset of action and short duration of effect. This agent is administered as an intravenous infusion. How to prevent hypertensive crisis? The most important thing that a person with hypertension can do to prevent hypertensive crisis is to take their blood pressure medication exactly as prescribed. People who often did not take their blood pressure medications were more likely to be hospitalized for heart problems. Some lifestyle changes that people can make to help lower their blood pressure and reduce the risk of experiencing hypertensive crisis include: eat a healthy diet. A healthy diet is one that is rich in fruits, vegetables and fiber, and low in fat and salt. Lower in salt intake can directly lower blood pressure. Dietary approaches to stop hypertension eating plan for people looking to lower their blood pressure. This is a calorie-controlled, heart-healthy eating plan that does not require any special foods. Limiting alcohol intake to the recommended levels will help lower blood pressure and improve overall health. Keep physically active. Getting regular exercise helps keep the heart and the circulatory system healthy. Avoid smoking. Smoking raises a person's blood pressure and increases the risk of experiencing cardiovascular issues such as heart attack and stroke. Get enough sleep. Good sleep is important to overall health, but it is especially important for the heart and circulatory system. This is because blood pressure drops during sleep. Adults should sleep at least 7 hours. There are some factors can help improve a person's sleep hygiene are getting plenty of physical activity during the day, waking up and going to sleep at the same time each day, following a consistent bedtime routine, ensuring that the sleeping environment is cool, dark, comfortable and free from noise and other distractions. Complications of hypertensive crisis include pulmonary edema, hypertensive encephalopathy, heart failure, heart attack, aortic dissection, stroke, bleeding around the brain.